In the present era, the general population is familiarized with Parkinson's disease due to its huge relevance. Even though its importance, when you ask people about the biology and physiopathology of the disease, they do not neither explain it nor understand. Hello, my name is Paula, a future biochemist, and this is Pause on Science. Check it out. Oh, there you are. Here we have more questions to answer about Parkinson's disease. Let's get started. First question. Let's answer this question. Can you explain the different tests that support the diagnosis of PD? Error rates in clinical observation highlighted the necessity of having additional tests that could improve the diagnosis process of PD. The first ones are the neuroimaging test. In this group, the most common one is the DAT SPECT, which is a reliable tomography test to distinguish PD from other disorders. The second ones are the genetic tests. In the last decades, molecular mechanisms of PD have been more understood thanks to the development of techniques in genomic editing. Discoveries in mutations in genes such as NACA have been very helpful for the understanding of the PD. The third ones are the olfactory tests. In PD, there is a condition named as hyposmia, which is a loss of olfactory function. It is present in the 90% of the patients, and it is one supportive criteria for the diagnosis of PD. The last one is the evaluation of the levels of neuromelanin. To analyze the progression of PD, you can measure the levels of this compound. Neuromelanin, present in human brains, is a polymer with dark pigmentation that is present in the membrane of the dopaminergic neurons. In PD, as we know, these cells are affected, and in that situation, they release large amounts of neuromelanin, which produces and causes the neuroinflammation. This ends up in the death of neurons. Second question. Oh, there you are. We have another question. Let's answer it. What can you tell us about the treatment of PD? The moment in which a patient should be given an appropriate treatment is determined in consensus with the individual. This decision stands on how motor and non-motor features affect the patient. Also, we have to take into account the employment, the level of lifestyle, the psychiatric issues, and the age. An earlier treatment is becoming more and more useful. Like this, we don't have to wait until other problems appear in other parts of the body. Now, I'm going to explain you the two types of treatments that are available for PD patients. The first one are pharmacological treatments, and the second ones, the surgical ones. The first ones are the pharmacological treatments. Their objective is to replace the dopamine levels that have been notably reduced. The first one and most common pharmacological treatment is L-DOPA. In 1960s, clinicians observed the absence of dopamine in brains of PD patients. Like this, they started working with L-DOPA administered intravenously. In the dopamine synthesis pathway, L-DOPA is the exogenous precursor. We choose L-DOPA instead of dopamine itself because L-DOPA can cross the blood-brain barrier. Instead, dopamine cannot. The neurons that survive in substantia nigra, together with other additional dopaminergic neurons present in other brain areas, they start synthesizing dopamine, causing the relief in patients as they compensate the loss. There are few adverse effects such as hallucinations, dyskinesia, and somnolence. The second ones are dopamine agonists. These are drugs that imitate the effect of dopamine. They stimulate dopamine receptors so that they can synthesize more dopamine. The third ones are MAO and COMT inhibitors. I will explain them together as they have similar mechanisms. In the brain, we have two groups of enzymes, the monoamine oxidases and the catechol O methyltransferases, which are in charge of the degradation of dopamine. This event occurs when the body sends a signal to these enzymes telling them that they have enough dopamine levels synthesized. That's why in PD, as we don't have enough dopamine levels, we send an inhibitor to these enzymes so that their activity stops. The fourth ones are the anticholinergics. They target acetylcholine, who has the function of generating involuntary movements in muscles. In PD, the use of these drugs causes the relief of usual symptoms, such as tremor. The last one is antiviral agent amantadine. In the brain, we have the NMDA receptor that triggers the rise of the dopamine release. Amantadine is an antagonist of the receptor, which means that it inhibits its activity. Like this, PD symptoms are reduced, but also the dyskinesia produced by L-DOPA is eradicated. We have to be careful with amantadine as it can generate renal damage. The second ones are surgical treatments. We will start with the deep brain stimulation. This is an alternative therapy that has shown positive results. It consists of the implantation surgically of distal electrodes connected to a neurostimulator in the chest. Through the electric currents delivered by the electrodes, it can modulate the networks in the brain. This stimulation gives the possibility to reduce the medication dosage given to the patient, allowing to have a softer response during the day. The second surgical treatment is carbidopa and levodopa enteral suspension. This is a treatment in which a levodopa gel is administered continuously in a patient through a pump. This pump is programmed in clinical centers and is surgically implanted, which provides more plasma levels than the ones in oral administration. There are some side effects, such as abdominal pain, complications in the insertion of the tube, and the dislocation of the tube. Okay, so this is the end of the second video.